Hey guys, how are you? Welcome back. I'm Dr. Chopra. I'm one of the sleep medicine doctors at work here. In this video, we'll be talking about snoring and sleep apnea. In the process of sharing information about that, we're going to start off with a little bit about normal, healthy breathing. We'll talk about snoring. We'll talk about sleep apnea. We'll talk about what causes snoring and sleep apnea. We'll talk about the consequences of untreated sleep apnea. And we'll also talk about what are some of the solutions that are available for sleep apnea. In a separate video, I'll be talking about what are some conservative interventions for snoring and sleep apnea. And there's another video where we'll be talking about what are some CPAP alternatives if CPAP is something that you've been struggling with. So with that being said, let's sort of jump right in. So before we, talk about abnormal breathing, we need to first talk about normal breathing. Let me get this out of the way here. And, when we're awake, we don't really have to think about breathing. It's like the heart just kind of beats on its own. Our brain tells our body, our diaphragm, muscles of respiration to continue to breathe on their own. Breathing is regulated by oxygen, as you're all aware, as well as carbon dioxide. Like if I asked you to hold your breath for 30, 40 seconds, you may or may not have a substantial drop in your oxygenation, but a very subtle rise in carbon dioxide will make you want to breathe more. The shortness of breath that one gets is primarily from an increase in carbon dioxide rather than a significant drop in oxygenation. And, during wakefulness, we don't really have to think about breathing. There are receptors in our blood vessels, in our lungs, in the muscles, in the brain that are maintaining this sort of what we call homeostasis, this balance of carbon dioxide, muscle stretch, oxygen, pH, to maintain a healthy level of breathing. And normally, one breathes through their mouth, breathes through their nose. Air flows through the airway, the nasal passages, the back of the throat, the trachea, the bronchioles, and then the respiratory bronchioles, and goes to the lungs, where ambient air is exchanged. Oxygen is exchanged for carbon dioxide, and when one exhales, all this carbon dioxide is exhaled. And we do this like thousands of times a day, and we don't even really have to think about it. This kind of changes, though, as we go to sleep. When we're sleeping, how the brain interacts with the muscles of respiration, muscles of the airway, that changes across different stages of sleep. And what happens is how the airway then collapses, or if one stops breathing during different stages of sleep, is also heavily influenced by what body position one could be in, the effects of gravity, the size of the neck, and so forth. So that sort of sets the foundation for someone to have what's called some pathology in breathing during sleep. That's called sleep disordered breathing, and of which snoring and sleep apnea is a component. And as we think about, what is sleep apnea, it basically refers to, as the name suggests, some cessation or reduction in airflow during sleep. If that cessation or reduction in airflow is due to some kind of a mechanical obstruction, the tongue falling back, the tonsils being enlarged, a deviated nasal septum, enlarged turbinates, small nasal passage, small back of the throat, too much adipose tissue deposition in the neck and airway. If there's a mechanical obstruction during sleep, that's called obstructive sleep apnea. Or if the brain forgets to remind the body to breathe because of dysregulation of carbon dioxide or oxygen or something of that nature, then that's called central sleep apnea. Most people have obstructive sleep apnea. Central sleep apnea is also, it's not uncommon. It's more common, especially if one goes to like altitude. But obstructive sleep apnea is the primary type of sleep apnea, and it can happen either during different stages of sleep, REM sleep or non-REM sleep. So that's a little bit about sleep apnea and its types. And I talk a lot about this. This is a wonderful picture by the Breathe Institute that sort of highlights the differences in nasal breathing versus mouth breathing. So normally, the physiologic way to breathe is nasal breathing. Mouth breathing, although common, it is pathologic. And one should be focusing on being a nasal breather as best as they can. In this picture, this is kind of sort of highlighted because people who from childhood into adulthood who are mouth breathers, the shape of their face changes over time. People who have chronic nasal obstruction, they have a nasal tone of voice. They can sometimes have this like receded mandible, which is the jawbone. The head posture, trying to compensate for not being able to breathe well or a small airway, they tend to sort of slouch a little bit forward. So having children be nasal breathers versus mouth breathers is important, and the anatomy develops in that specific way. And as one gets older and as the anatomy develops, people who are chronic mouth breathers, because their bony structure is such, they tend to have smaller upper airways. So this sort of sets the foundation for, a thin male who has a small mouth, who is a mouth breather. In that individual, a small upper airway is likely the driver of sleep apnea versus someone who is primarily a nasal breather but has a body mass index of say 40, morbid obesity. In that individual, it's really obesity that's the driver. So we try to figure out what's the driver of sleep apnea in what individual, and the anatomy of our head and neck plays a big role. Mouth plays a big role in the anatomy of the airway, and if the airway is small, one is at a higher risk of developing sleep apnea. So this is an example of someone who has that craniofacial anatomy that is conducive to a small airway. This is an example of someone who has who has good craniofacial anatomy with good jaw placement and has a healthy size airway. This is not diagnostic of sleep apnea. It just sort of sets the foundation of who is at a higher risk of having sleep apnea versus somebody else. And the reason this is also why mouth breathing and nasal breathing, why this conversation is also important, is because if you think about the idea of snoring, like if I'll snore for you, like I have to typically, it's easier for me to snore when my mouth is open versus if I try to snore with my mouth being closed, it's much harder. And snoring, the sound of snoring, the vibratory sound of snoring is primarily with the tongue falling backwards, bouncing against the back of the throat or the soft palate, creating this sort of near obstruction that is happening that creates the sound of snoring. Snoring is usually a precursor to developing sleep apnea in the future, or they may already have sleep apnea. So snoring is something that we want to think about and try to address as best as we can. And one way to do that, one way to sort of reduce the amount of airway collapse is by keeping the mouth closed. So if someone's mouth is closed and they're laying on their back and they're asleep, the tongue gets sandwiched sort of between the hard palate and the mandible, which is the jawbone. And if one is able to breathe well through their nose, this is the mechanism of how sometimes you may have seen this on social media, or you may have read a paper on this, where keeping mouth, by reducing the amount of mouth breathing and promoting nasal breathing, some people can actually mitigate, reduce, and sometimes cure themselves of sleep apnea. It's basically helping put the tongue in the right position, preventing it from collapsing backwards, and allowing one to have a healthy upper nasal and upper airway. So keeping the mouth closed is important during sleep. So what are some other risk factors? We talked about narrow airways. Men, unfortunately, are at a higher risk of having sleep apnea, except post-menopausal. The prevalence of sleep apnea in men and women kind of equalizes. As we get older, the prevalence of sleep apnea also increases. If we have a family history of sleep apnea and snoring, the likelihood of us having it is also higher. And this kind of feeds into the idea of the shape of the face. How we look is determined by our parents, or it can be determined by our parents. And that craniofacial anatomy, if it was small to begin with, sets the foundation of one having a smaller upper airway and therefore increasing the risk of having sleep apnea. Alcohol, sedatives, these increase the risk of having sleep apnea. Smoking, menopause. With menopause, the prevalence of sleep apnea almost doubles during the transition from a reproductive age to a non-reproductive age. We talked a little bit about how the nose plays a role. So when there's chronic nasal congestion, if someone can't breathe through their nose, the likelihood of sleep apnea is substantially higher. I've taken care of many people now who, when we treat their chronic nasal congestion with whatever modality, the burden of sleep apnea can drop by more than 50%. And it's such a low-hanging fruit that if someone does have chronic nasal congestion, this needs to be addressed. The prevalence of sleep apnea is also much higher in people who have heart failure, although in this situation it's primarily, central sleep apnea is much more common. People who have diabetes, people who've had a stroke in the past. We talked about the brain regulation of carbon dioxide and oxygen. So if the brain has been injured in the past, the likelihood of having sleep apnea is much higher. If someone has underlying lung disease like COPD, asthma, tracheobronchomalacia, any underlying pulmonary disease will increase the risk of having sleep apnea. Genetics play a role. If someone has too much weight or a large neck, specifically if it's more than 16.5 centimeters, that individual is at a higher risk of having sleep apnea. So these are all the risk factors. Some of these are modifiable, some of these are not. So those that are modifiable, those become a part of our strategy of what are some of the things that we're going to focus on while we treat sleep apnea. What are the things that we can focus on that can be sort of eliminated as some of the drivers of sleep apnea? For example, if in someone their weight is the driver of sleep apnea, losing a substantial amount of weight can reduce the burden of sleep apnea. And I've actually taken people off of CPAP because they've lost a substantial amount of weight. And in today's age, with these medications like Mounjaro and Ozempic, amazing exercise routines that are available, this can be a very powerful way to liberate yourself from sleep apnea. So what are some of the symptoms? We'll talk about short-term symptoms and long-term symptoms. And the way I like to think about short-term symptoms are, what's happening during the daytime and what's happening during the nighttime. Daytime symptoms are, because one has not slept well, they'll feel sleepy during the day, fatigued during the day. Because someone's been breathing through their mouth or snoring their entire night, the upper airway, from that sort of chronic vibration, one can have a sore throat. One can also have headaches in the morning. Because people haven't slept well, they may have difficulty with concentration, and they may have memory or mood issues. Nighttime symptoms are things like snoring. A bed partner may say, "Hey, my significant other stops breathing, and I have to nudge them to wake them up so they can start breathing again." So witness apneas, feeling very restless during sleep, sometimes not being able to sleep. This is important. People think that going to the bathroom at nighttime is primarily because of a prostate issue, but having to take frequent bathroom breaks at nighttime can also be sleep apnea. And lastly, just waking up in the morning not rested, feeling like I just never slept at all. So nighttime symptoms can be prevalent, or daytime symptoms can be prevalent, or both. So what happens during this apneic event, this pause in breathing? One is there's a drop in oxygenation. If I hold my breath, oxygen levels will eventually drop, and over a course of some period of time, the carbon dioxide levels will start to rise, and this combination of things will cause my brain to wake up in sort of a fight or flight response. It's called a sympathetic response. This sympathetic response activates the cardiovascular system, the autonomic nervous system, and this sympathetic response causes blood pressure to go up, it causes heart rate to go up, it causes one to feel anxious. in the middle of the night. So people who have sleep apnea, they go through cycles of this many times an hour. Sometimes it's just 7 to 10, 5 to 10 times an hour. Sometimes it could be north of 50, 60 times an hour, almost once a minute. So I like to use this analogy in clinic often. We always talk about like why is sleep so important, and I always try to explain this to patients from the standpoint of like imagine a hotel. Imagine a hotel where the housekeeper has been coming 7 to 9 hours a night and doing a phenomenal job, and you have another hotel where the housekeeper is coming in, say, 5 hours a night and is being interrupted, pulled in multiple directions, and is not doing a very good job. Over a course of 20, 30 years, the hotel that had the housekeeper for only 5 hours and wasn't doing a good job, that hotel is going to be a much more rundown hotel as compared to the other one where the housekeeper was coming in for 7 to 9 hours a night and doing a phenomenal job. And, sleep is the housekeeping process for our body and our physiology. Sleep appears as a passive process, but it's a metabolically extremely active process. So when we think about helping one improve their sleep, we're trying to help them restore the physiologic processes of sleep. So over a course of time, that body is more restored, has a longer health span, has a longer lifespan, and it's a much more well kept hotel as compared to someone who's been a poor sleeper their entire life, and that person is at a higher risk of a whole bunch of downstream consequences. And this is fundamentally why people who have sleep apnea for decades have a whole bunch of downstream consequences, whether those are neurologic, mental health related, cardiovascular, or metabolic. Neurologic being people who have sleep apnea, especially if severe, are almost at a 6-fold higher likelihood to develop a stroke, a 6-fold higher likelihood to have a heart attack. The likelihood of developing dementia or Parkinson's disease is much higher. Mental health disorders like anxiety and depression is much higher. Cardiovascular disorders like having high blood pressure, whether that's refractory hypertension, meaning they're on multiple medications to try to treat the blood pressure and it's still difficult to treat, or if they've had, or something like coronary artery disease or having a heart attack, or these like sympathetic activation that's happening in the middle of the night can cause people to have people who have long-standing sleep apnea are at a much higher risk of having atrial fibrillation, almost a 3 to 6-fold increase in likelihood of happening. And also people who have sleep apnea, they're at a higher risk of developing fatty liver, poor glucose regulation, prediabetes and diabetes. They wake up sometimes with high cortisol levels in the morning, and also people who have sleep apnea may have a difficult time losing weight. So treating sleep apnea, one is, we're trying to address these sort of acute short-term symptoms of how someone feels, but what we're really trying to do is help people mitigate the burden of having these downstream consequences and allowing one to be something like this sort of hotel versus something like this over a course of many decades. How do we test for sleep apnea? One of the tools that we've been using at Empower Sleep is this Sleep Image home sleep testing system. It's FDA cleared to aid in the diagnosis of sleep apnea, understand one's sleep quality, and we also use this as a longitudinal tracking tool. So how things work at Empower Sleep, we'll do about 7 to 14 nights of testing up front to really understand what one's sleep is like. And then if we decide to make any recommendations, we have one track their sleep across time using these recorders, and that allows us to see if these recommendations that we're making, are they working or not. It's sort of like if you have a cardiologist who's taking care of you, who's managing your blood pressure or hypertension, and they gave you a Bluetooth enabled blood pressure monitoring device, and the doctor is saying, hey, check your blood pressure every in the morning and in the evening, here's some lisinopril or a beta blocker or some medicine to take, and over the coming weeks or months, I'm going to help you using the data from the blood pressure cuff and the medication that you're on, help you optimize and get you on the right dose of the right medication so that this is no longer an issue. So we use these tools both as a diagnostic tool, but then also as a tracking tool to be able to help somebody get to a place where they can have the healthiest possible sleep. The outputs that we get from these recorders is very comprehensive. We can understand what's happening to sleep quality. We can understand what's happening to sleep pathology. We can understand one's overall sleep architecture. We can see what's happening to oxygenation, motion during sleep, any kind of fragmentation. So we get a lot of information, and we use this information to then make more educated decisions rather than this idea of, symptom-based medicine. It's better to use data to figure out what's going on, when is it happening, and how do we mitigate the burden of that problem as best as we possible. It's sort of like, think of it as if I have a chronic cough, just taking antibiotics is like not a very intelligent thing to do. Like one should do an x-ray to see, hey, is there anything that I'm missing before I prescribe anything. So similarly, if someone tells me, hey, I don't sleep well, I have bad sleep, I have poor sleep, I have a suspected sleep disorder, instead of prescribing a medicine or prescribing some kind of a treatment, the best thing is to do a sleep test and understand their sleep so one can be more precise with how they approach the problem. Using the test, we can quantify one's sleep apnea. The way that sleep apnea is quantified is based off of how many times per hour does one stop breathing or have a reduction in airflow. If someone has more than 30 pauses in breathing per hour, that's considered to be severe sleep apnea. If someone has less than 5 pauses in breathing per hour, that's considered to have no sleep apnea. And this is important to know because one can be a good sleeper and also have substantial sleep apnea, or one can be a poor sleeper and also have sleep apnea. So there is like a sort of, if you think of a Venn diagram, there's an overlap between sleep apnea and sleep health in general. Both influence each other. One should not think of this as just because I have sleep apnea, I'm also a bad sleeper. Sometimes we have people that are amazing sleepers even while they have severe sleep apnea. Those people do really well with any kind of treatment. When someone is a poor sleeper to begin with, and on top of that now they have some level of sleep apnea or sleep disorder breathing, that person can be a little bit more harder to treat effectively. So think of it as two separate things: sleep health, one, and sleep apnea burden, another. Both influencing each other in a significant way. Through the app, through the Empower Sleep app, you're going to be tracking your sleep on a night-to-night basis. You'll be able to see what's happening to sleep quality. You'll be able to see how many respiratory events, these pauses in breathing, these apneas that you're having per hour, how much you're sleeping. We're going to ask you to journal in the app so that we can start having some associations to see what's working and what's not working. And then based off of, at least getting maybe 7 to 14 nights of data, we'll be able to then come up with a more personalized care plan based off of your symptoms, the subjective symptoms that you tell us, and the objective things that we find from the sleep test. We'll be able to discuss the different treatment options. I'll go ahead and discuss some of these options in this video too, just so you have some context of what the conversation is going to be like when we meet in person, when we meet virtually. So, CPAP is one solution for people who have sleep apnea. The way CPAP works, CPAP stands for continuous positive airway pressure. It's basically sort of like a reverse vacuum. It blows air in through some kind of a mask interface. It can just cover the nose or the mouth and nose, and this positive airflow prevents the airway from collapsing, and it keeps it open and patent during sleep, And if it's maintained, kept open and patent during sleep, then there's less pauses in breathing. If there's less pauses in breathing, there's less arousals that happen. And also, if there's less pauses in breathing, oxygen levels remain more stable and there's less drops in oxygen. So this is CPAP. One thing to be thoughtful about CPAP is it's not like a one size fits all. The CPAP comes with, sort of factory settings, but there are many different changes that can be made to pressure, to airflow, to the kinds of mask, to temperature, to humidity. So think of, I always tell patients, think of it as getting a new phone. You get a new phone, it comes sort of with factory settings, and then you personalize it based off of your needs. Like, what do you want on the home screen? What apps do you need to download? Similarly, like the CPAP machines are the same way. What's the mask that you like? What's the pressure that will work for you? What's the temperature, the humidity? All of these different settings, and your providers are going to help you figure that out. Another solution for people who have sleep apnea are these dental appliances. They're called mandibular advancement devices. In this example, this is a custom fabricated one made by a dentist. Specifically, we recommend seeing a sleep apnea or a sleep and airway dentist who does this for a living. And the way these work is, we talked about how the tongue plays a role in collapse of the upper airway. These appliances advance the mandible forward a few millimeters, to create more space in the back of the throat. And if there's more space in the back of the throat, assuming that that this was the area of obstruction, the burden of sleep apnea goes down. And these can work reasonably well also. The other options for sleep apnea are this device called INAP. This stands for intermittent negative airway pressure. And then just mind you, all the things that I'm talking about right now are prescriptive interventions. I'm not talking about the conservative interventions or I'm not talking about the conservative interventions that can be used for sleep apnea. We're talking about purely like the different prescriptive solutions that are available. This is an INAP device, intermittent negative airway pressure. One puts this mouthpiece in their mouth, and this canister here, part of this is a saliva collection container. Part of this is sort of like a reverse vacuum. And it basically sucks the tongue a little bit forward while still keeping it in the mouth. It sort of creates a vacuum within the oral cavity to keep the tongue a little bit forward, and therefore allowing one to breathe better through their nose and having more space in the back of the throat. So this is how the INAP device works, and we'll talk more about this when we meet with you in clinic. And this is something that you probably have seen on television. It's called Inspire. It's kind of like a pacemaker for the tongue. And the way this works, this is implanted by an ENT doctor. And the way this works is when the sensing lead senses that that one is having a difficult time in breathing, like there's an increase in work that the muscles of respiration are having to do, it'll stimulate the tongue muscle and push it out of the way. So it's kind of like a pacemaker for the tongue each time it falls back and obstructs the airway. And this is an implanted device by an ENT doctor, and this can also work for people who have sleep apnea, specifically those who have a lot of intolerance to CPAP. It's not something first line. We think of this as something that one has tried CPAP, one has tried a dental appliance, they've tried a whole bunch of conservative interventions, and it has not helped, and Inspire is something that we can consider at that point in time. Another tool that's available, this is also prescriptive, is called Bongo. It's the way these, it's sort of like a one-way, sort of a pseudo one-way valve. One puts these little plugs inside of their nose. One can breathe in through their nose, but when they exhale through their nose, it creates a little bit of resistance. And that resistance then therefore helps one keep their airway, upper airway, more patent. There's more expiratory pressure in the upper airway that, in theory will keep the tongue out of the way and keeps the airway more patent, and therefore less obstructions, less arousals, better sleep. Bongo can work well for people who have, snoring and mild sleep apnea. I have not seen anybody be successful with bongo if they have moderate or severe sleep apnea. Bongo can be added to, say, someone had a significant reduction in apnea burden with a dental appliance. There is still some residual apneas that are happening, and then bongo can be added to that as a stack, as an additional solution to help them, feel and do better. So bongo is also a tool that is available. It's by prescription only, unfortunately. And then lastly, I'll talk about this device called Excite OSA. This is kind of like so all of the solutions that I've talked about so far, bongo, Inspire, INAP, dental appliances, and CPAP, these are all nighttime solutions. One uses them during the night. Excite OSA is a daytime solution. One uses this 20 minutes twice a day in the morning time. And the way this works, it's kind of like a tongue stimulator that it causes one to exercise the tongue muscles for 20 minutes twice a day. And by doing so, if the tongue muscle itself is more stronger, there is a lower likelihood of it collapsing backwards, causing an obstruction. So if the tongue muscle is stronger, less likelihood of falling backwards, and this could be an effective solution for someone who has snoring and mild sleep apnea. And then lastly, there are different surgical options that can be used for people who have obstructive sleep apnea. I know we talked about this implantable nerve stimulator, so you can ignore that, but there are different surgeries that are available for people who have sleep apnea, and they basically focus on creating more space in the upper airway, and they also focus on trying to identify what is the point of obstruction. So before any kind of surgery is done, the ENT doctors will do what's called a drug-induced sleep endoscopy. It's called a DISE, drug-induced sleep endoscopy. During this drug-induced sleep endoscopy, they will go in with a camera and look visually where are the different sites of obstruction, and then those specific sites can be surgically worked on. So that's sort of how the foundation of how these ENT surgeons will think about doing different staged surgeries for people who have sleep apnea. They can be very effective. The way that I always think about this is, let's put out the fire first with something that works. It could be a CPAP, a dental appliance, INAP, and then work towards a more definitive long-term solution like surgery. Because let's say someone has severe sleep apnea, that if they tolerate CPAP, that person is going to do better with surgery afterwards, because that person has better oxygenation during sleep as compared to someone who still has severe obstructive events during sleep. So, surgery is totally something to consider, but I always try to think about this, that let's first treat the sleep apnea medically while keeping our minds open about different surgical options in the future. And I think that's it. Okay, well, good. Well, I hope you found this video useful, and we'll talk to you in clinic, and we'll discuss, what you feel would be a good option for you, and we can sort of take it from there. Take care. Bye-bye.